total resection, 67 versus 48%. Visual improvement is also more in endoscopic surgery. When you compare endoscopic endonasal with microscopic transfemoral, the outcomes are similar. Though CSF leak is more in endoscopic surgery, transcranial surgery obviously had more risk of seizures. So this is the most recent published case series, and with the highest number of patients. So this was published by our Korean friends, 182 patients. They classified their tumor into intracellular, intra and supracellular, and third ventricle extension. And they had gross total or near total resection in almost all of the patients. So gross total was 86% and near total was 20, so showing that they underwent radical resection. So the new onset hyperpituitarism occurred in about 50% of patients, and a new onset diabetes was there in 26.4 patients. There was visual improvement in 110 patients out of 182 patients. According to them, for intra-supracellular lesions and supracellular tumors, patient in the endoscopic endonasal approach has higher gross total resection, lower incidence of hyperpituitarism, and better visual outcomes. Tumor recurrence was 6.6 group. Now, if you compare outcomes of craniopharyngioma surgery, so this is another review. It includes 540 patients. Out of it, 130 only underwent biopsy and radiation. Follow-up was about 54 months. So their overall new endocrinopathy for all patients undergoing surgical resection was 37%. So according to them, if patient received gross total resection, he has about 2.5 times the rate of at least developing one hormonal issues. When you compare that with subtotal resection or subtotal and radiation, and patients who undergo radiation has a more bad visual outcome when you compare to those who have not received. So according to them, aggressive surgical resection had led to some, the general goal of gross total resection in all cases might lead to unacceptable rate of endocrinological issues, behavioral issues. So the preoperative evaluation, we all know, has to be a full endocrinological workup. You check visual perimetry, you do a high resolution.
1 minute, Saad.
You did pituitary hormonal status, very important. The operative status, where it is a prechiasmatic or retrochiasmatic, whether there's hydrocephalus, prior treatment, if they have radiation endonasal surgery, wide variety of surgical. The recurrence is in the first 3 years, the recurrence is mostly cystic. If the lesion is calcified and involving the floor, the recurrence rate is, there's a very high chance of recurrence. The overall survival for adults is about 89 to 94% in 5-year survival, and it's the same for children. Talking about hypothalamic injury, it's one of the grave complication, either traction or injury. It can lead to hypothalamic obesity, more common in children is loss of circadian rhythm, diabetes insipidus, and congenital failures. If there's hydrocephalus, you need to put an EVD or VP shunt. Now, talking about cyst management, which is one of the form of recurrence, and it is difficult to manage. You can put an Ommaya reservoir, you can do serial aspiration, you can do instill radioactive isotope, you can instill interferon, or you can aspirate and reduce it to a size that is amenable to stereotactic radiation surgery. This is a paper which says that serial aspiration can be done in candidates which are not for surgery now, or in pediatric population when you want to delay radiation. Talks about brachytherapy, use of yttrium, phosphorus, and interferon. Have to mention Dr. Ommaya's name. And coming on to radiation therapy, the recurrence-free survival in 10 years after subtotal resection plus radiation is 80%. Is gross total resection a form of cure? I don't think it is, because this paper clearly indicates that even patients who underwent complete resection had relapses. Long-term outcome, we've already discussed about this. So this is a paper on quality of life, and it talks about hypothalamic sparing treatment are recommended. Because otherwise you will leave the patient with a grave complication. This is a registry from Germany, the Craniopharyngioma group, and they talk about less radical surgical approach, and to reduce the rate of hypothalamic lesion, hypothalamic injury. Probably this is my last slide. This paper actually shows a pathway for 2 different type of patients. The good risk patient are those with small tumors, with no hydrocephalus, with no hypothalamic syndrome, and no breach of third ventricular floor. You should try and excise these as much as possible. The poor risk patient are those with larger size hydrocephalus, hypothalamic syndrome, and breach of third ventricle. Here you should go for a subtotal resection, and then you can follow patients up. If there's incomplete resection and if the patient is young, you can just wait. Older patient can go for radiation. So the summary is that craniopharyngioma is a difficult disease to treat, needs a multidisciplinary approach. You should know the goal of surgery. You should know prehand if you will be able to spare the hypothalamus or not. You should know the expected morbidities, and if needed, you should consult a regional or international expert. Thank you.
Thank you.